Hello. Dr. Leibert here. If you're watching this, it's because Harvey, the tropical storm, is causing some issues, and I won't be able to get out of South Texas and over to Belton. But I wanted to just share with you for a few moments. There are plenty of storms that happen in our lives. Today I was working with a group of school children talking about the Pilgrims and their journey on the Mayflower. I have this little reminder of a recent visit to Leiden, Netherlands, and to Rotterdam and Delfshaven, where I had the privilege of visiting the last church in Holland where the Pilgrims prayed, prepared for their journey on the Mayflower to a very new and harsh, beautiful, untamed world that they brought the word of truth through the Bible, the word of our Lord Jesus, to a new continent. And just reminded me as I was sharing with the children about that 2-month passage for those 36 pilgrim moms and dads, and 7 daughters and 13 sons, how difficult that voyage was in rather graphic terms. So they would understand this was not a pleasure voyage. But the same Jesus who calmed the winds and the waves 1600 years before was still able to do it for the Pilgrims and is still able to do that for us now. So that's good news. We don't have to fear the wind and the waves. Let me pray with you. Father, I do thank you that we don't have to fear the storms of life. There will be there, and we will help people navigate through those because of illness, bodily injury. That's being a part of the healing art, is bringing the hope and the help of our Lord Jesus into lives. For the winds and the waves still know his voice who ruled them while he dwelt below. That's good news. And we praise you in Jesus' name. Amen. Life on the farm. Here we go. Let's talk about some different classes of medicines. Now you'll notice that what I do throughout is to talk about the different classes of medicines. And let's see if I can get my little drawing pen here. There we go. And so we'll talk about the class of medicines, and we'll have a model, one particular medicine that I've chosen to be the representative of a certain group. Like here we're talking about the adrenergic antagonists, the alpha blockers in particular, tamsulosin or Flomax, and I also put up terazosin or Hytrin. In that same category would be Cardura or doxorubicin. Their mechanism. Flomax in particular is specific for the alpha receptors in the prostate and the bladder neck. Therefore, it's great for BPH as well as kidney stones by dilating the ureters and helping the kidney stones to pass, particularly the distal stones. Hytrin, on the other hand, is also a potent vasodilator and has prostate effects, so it can be used for both BPH and hypertension. Interesting, isn't it? It's not cheap, and neither of them are cheap as far as expense. But if I have a patient who's a 70-year-old who needs a mild antihypertensive as well as some help because he's having nocturia because of BPH, then Hytrin, 1 milligram QHS, reasonable choice. I also always make sure the metabolism, there's another M, so we've talked the model, the mechanism, the metabolism is in here. That's liver metabolized with urine and feces excretion. And finally the mess, i.e. the side effects. So for instance, the alpha blockers can cause, the alpha 1 blockers can cause some fluid retention, so you have to be careful with their use in CHF patients. They can cause orthostatic hypotension, particularly Hytrin, Cardura, because they drop the blood pressure. Flomax rarely does that. So be careful with these medicines in the elderly and give at bedtime. Kind of makes sense since we're using them in particular to help with the prostate issue. Okay, let's talk about a huge, important class of medicines, the beta blockers. Metoprolol, low pressor, or toprol, comes in different forms. There's the tartrate form, which is short-acting and costs about $4, and the succinate form, or the long-acting medicine, which can cost anywhere from $20 to $60 a month. So obviously, I like the tartrate. Inexpensive. You have to use it BID versus the Q-day of the succinate version. But to me, the inexpensive medicine with the same power is worth it. Mechanism, we have to remember that beta blockers block down at the atrioventricular node, the AV node, so it will slow conduction, so it will cause some bradycardia, but great for rate control and AFib. It can also prevent some dysrhythmias. See if we can spell that right. So very good in AFib right there. Put that little there for you. Let me get my little drawing pen back. Okay. Myocardium decreases contractility. It is a powerful tool in coronary artery disease. Like aspirin, has been shown to decrease mortality. So a beta blocker, next to aspirin, the two most important meds for a patient who are having ischemia, injury, or myocardial infarction. Very important. Now, in CHF, there is a place for it, but you don't want to use it in the patient that's acutely in failure. For instance, Miss Perez, a 68-year-old, comes in and she's short of breath. She has pulmonary edema. Her legs are this big due to backflow edema. That's the patient where use your nitrates, your oxygen, the ACE inhibitors, some diuresis with Lasix, and then as she's out of the acute phase and her EF may be 25-30%, then you slowly begin the beta blocker. The beta blocker decreases the adrenergic punch, the adrenaline punch on the heart. By blocking that, it improves cardiac function, decreases mortality in the CHF patient over time. But you titrate it slowly and be careful with it. Beta blockers have been used to decrease intraocular pressure in glaucoma. Metabolized in the liver and excreted in the urine. The problem with beta blockers in the patient that has asthma, COPD, just be careful. It can cause some bronchoconstriction, bronchospasm, because it hits those beta receptors in the lung. It can worsen peripheral vascular disease. Oh, that was nice. So be a little careful in the patients that have claudication. You can still use it. You just have to titrate it slowly and carefully so you don't actually worsen peripheral vascular disease. Beware AV blocking. Before you start beta blockers or central acting calcium channel blockers, make sure you get an EKG. Never use a medicine that causes dysrhythmias or blocks the AV node without a baseline EKG. You got to make sure they don't have a second degree or a high degree, like a complete heart block, like third degree heart block, and you throw a beta blocker on there. Not a good idea. Cocaine users, please be careful with the beta blockers. By blocking the beta, they have pure alpha adrenergic stimulation of the heart, and they can actually precipitate an MI. In diabetes, not such a big deal. It can block the symptoms of hypoglycemia, those sweats, and the tachycardia. Obviously, because it's a beta blocker, it blocks at the AV node, blocking that tachycardia. Not an absolute contraindication. Certainly, I would still use it in the diabetic who has a coronary disease, but just realize you have to remind your patients to be careful of hypoglycemia. They may not have the symptoms. Abrupt withdrawal can cause rebound hypertension, so be careful. And we don't suddenly stop a beta blocker. That's a rebound. Because of the rebound hypertension. And of course, if you suddenly stop it in patients with coronary disease, you can precipitate an MI because of that unopposed alpha adrenergic stimulation. So please do not abruptly stop a beta blocker. He has to be weaned off if it needs to be taken off. Okay? Let's see. Let's try a little case here. See how what we can do with this. Okay, this is a 44-year-old college professor with a headache for 3 days that is worsening. It's interesting. Past medical history includes hypertension. Now, he stopped his HCTZ because he felt it wasn't natural. What do you do? So the HCTZ was stopped. He is allergic to lisinopril because it causes a cough. Lisinopril is an ACE inhibitor, angiotensin converting enzyme inhibitor, and one of its side effects is cough because the ACE, the metabolism, if you will, of ACE inhibitors involves the lung. Vital signs 210 over 120. Oh, wow. Pulse is 90%, sats good at 99%. Unremarkable exam in this patient with a very high blood pressure. So we've got a patient with headache and a systolic greater than 200, diastolic greater than 105. Patient has hypertensive emergency. Hypertensive emergency. Urgency, hypertensive urgency, is if the patient has systolic over 200, diastolic over 105, without symptoms, no evidence of end organ damage, headache, visual problems, chest pain, heart failure. But this patient has evidence of end organ damage, the headache, as well as the high blood pressure, making this a hypertensive emergency. Bah! Okay, let's take a look at his EKG. There we go. So let's we'll be going over EKGs over these next few years. Be teaching you my 12-pack, how to read EKGs systematically. Let's just do a few quick things here. We look for QRS hitting a sharp line, a dark line, if you will, and to get the rate 300, 150, 175. So the rate 75, there is a P wave before every QRS. So we can see the P waves there. Very nice. P waves. So definitely a patient with a normal sinus rhythm. The PR interval is normal. It's not greater than 1 big block. QRS is normal. It's not greater than 3 blocks. The QT interval is not greater than half the R to R. Again, I'm just going over this. You don't have to memorize it. I'm just exposing you to the 12-pack, if you will. The patient's axis is 60 degrees. It's most positive here in lead 2, so that's normal. Means the electrodes are measuring the vectors moving in the normal direction. Let's see the P wave morphology here in lead 2, and V1 is normal. The T waves, we're looking at the T waves, biphasic here in lead 1, inverted in AVL, a little peaked here in V3 and 4. And then the ST segments, we find something of a downsloping here. That same downsloping here in V6. Maybe a touch of it in V5, not so much. R wave progression, the R wave should get bigger, 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 bigger as we go, and that's true. Voltage, whew, look at this, 5, 10, 15, 20, 25, big, massive voltage here, both in the S waves in V2 and in the R waves in V6. So there's big voltage. So let's look at what we have. We have a patient with a normal sinus rhythm, rate's about 75, who has evidence of left ventricular hypertrophy, or LVH, left ventricular hypertrophy. How do we know that? Because the voltage here, those big R waves in V5 and 6, deep S waves in V2 and V3, are part of the criteria for left ventricular hypertrophy. So this patient has been dealing with hypertension. The afterload has been really high, and this poor heart has been beating against uncontrolled hypertension for a long time, causing thickening of the muscle of the myocardium. So the pump is thick. There's left ventricular hypertrophy. So what do? with a patient like this who has a hypertensive emergency? Well, while I'm waiting for the ambulance to come, because I never send cardiac patients in a wheelchair across from our clinic to the hospital. So 'cause we're just, a few steps away from the ER. But these patients need to have their monitors on, cardiac monitoring all the way, because you never know when something ugly is going to happen. We don't want them collapsing in the street. But while I'm in the clinic, and while we're waiting for the ambulance, Clonidine, 0.1 milligram, will bring the blood pressure down gently over about 20 minutes. That would be a good way to begin treatment. The patient needs to be admitted because it is a hypertensive emergency. We'll likely start medicines that he's willing to take. We need to talk about that, and we'll need to do a little bit of negotiation because he cannot run around safely with the blood pressure like this. And there's just not good complementary alternatives for hypertensive control in this setting. Okay, so he'll need to be on a medication. What's choice? I would talk to him about calcium channel blockers, particularly the central acting calcium channel blockers. Like to decrease that afterload. Consider nitrates like Imdur, dilating the peripheral arteries, decreasing the blood pressure that way. Need to talk to him about HCTZ. It's a good medicine. It decreases systolic blood pressure. It works very effectively in the elderly. Though he's at 44, he's not quite in that category yet. Okay, so we're talking about hypertensive emergency. If you need to use IV meds, you can use nitrates, you can use nitroprusside, you can use IV beta blockers. So there's different medicines that can be used IV. Our focus is in the clinic because that's where most of you are going to spend your time. Some will be in the emergency room, and some continue to enjoy that, and that's terrific if that's your calling. So let's look for just a moment at the alpha-2 blockers. Here's Clonidine or Catapress, the very medicine we were talking about. Get out color here. Okay, so Clonidine. Its mechanism, it decreases the central nervous system control of vasoconstriction, so it's very good in hypertensive urgencies and emergencies. It hits in about 20 minutes. It'll last for a few hours. It blocks some of the adrenergic stimulation, and so it can also be helpful in alcohol, nicotine withdrawal. Interesting that it can help in patients that have ADHD. I have one of my patients who takes it at bedtime. It helps him to sleep, truthfully. And he's started when he was 10 and has been taking it for the last 4 years with improvement. It helps with hot flashes, so it's an alternative to patients who aren't able or shouldn't be taking estrogen replacement therapy. It can help with restless leg syndrome as well as familial tremor. So the Catapress, Clonidine, has other uses. It should not be used first line as a long-acting hypertensive. Why? Because abrupt withdrawal causes rebound hypertension, and it's mean. Patients will forget a dose, and all of a sudden their blood pressures will be 200 over 120. So it should not be used as a chronic medication for hypertension. It should not. I don't use it chronically for anything, except we talked about low-dose ADHD. I have one patient on it. That's about it. Just because if they forget the dose, they can have a big rebound hypertension. It can worsen depression. It can cause some sedation. But the main thing for your exams and to know about is that rebound hypertension. So yes, the Clonidine has a place in hypertensive urgency or emergency. It's been a real blessing. I have a number of patients, each month that come in with hypertensive urgencies. They don't have to be admitted. And it brings their blood pressure down. Then we start or restart a long-term antihypertensive med. And it really is a great bridging medicine for patients. Okay, let's talk about the cholinergic agonists. The one you're going to see mostly is Aricept, medicines that are used for patients with Alzheimer's. Pyridostigmine, a medicine that's used in myasthenia gravis. I think the most important thing here is to remember sludge. salivation, lacrimation, urination, defecation, gastric irritation, and emesis. That's kind of a classic mnemonic for the side effects of cholinesterase inhibitors. Okay? Those are the same things that happen in patients that get pesticide poisoning. They get the sludge. How about cholinergic blockers, or what we call anticholinergic? Atropine, of course, is sort of the classic anticholinergic medicine. They can cause bradycardia at the heart because of the acetylcholine receptors. They can cause and help cause some bronchodilation, decreasing some of the mucus in COPD and asthma. They can be helpful in bladder receptors by decreasing urge incontinence. So a patient that has wetting themselves, can't get to the restroom in time, there's a place. You just have to realize there's some side effects. It can help with Parkinson's, so we don't use it much for that anymore. And home atropine can be used to dilate eyes in the setting of an acute iritis. Here's the old mnemonic for the side effects of the anticholinergics like atropine. Blind as a bat, dry as a bone, red as a beet, and mad as a hatter. So you just have to be careful. There's anticholinergic side effects in antidepressants such as trazodone, Desaril, older medicines we don't use so much anymore, like Elavil, as well as the anticholinergic side effects found in antihistamines from Benadryl to Zyrtec. So we've got to be a little careful with the anticholinergics. They have a place, not so much in cardiac disease. Okay. It's I don't think we're quite ready for that yet. Here we go. Okay, let's talk about our ACE inhibitors. Such an important and powerful group of medicines. Lisinopril is my model. It's inexpensive. It works well. Let me get my pen here again. So there's our lisinopril. Blocks conversion of angiotensin 1 to angiotensin 2. Here are some of its excellent mechanisms. It vasodilates, so it's helpful in hypertension, angina, post-MI. Patients need to have a ACE inhibitor started at some point, usually not emergently, not like the aspirin and the beta blocker, usually within 24 hours or so. Has been shown to decrease morbidity and mortality. Vasodilation of the efferent renal vessels, that makes it renal protective in diabetes. So your diabetic patients, particularly those that are wasting away in their urine more than 30 micrograms, 24 hours of microalbumin, need to have that renal protection. Some people believe that every diabetic should be on an ACE inhibitor from the beginning. You'll see some controversy or debate in that. I certainly make sure that any of my patients with more than 30 micrograms for 24 hours are on an ACE. It is renal protective. Has been shown to decrease renal failure in the diabetics. Other powerful uses of the ACE include CHF, and we already talked about the post-myocardial infarction. Now, some of the things we mentioned in our last case, the troubles, the cough, can be very annoying. It's a dry, staccato kind of cough. And that happens, patients come in, I've been coughing for months. Look and see if they're not on an ACE inhibitor. You just got to stop the ACE. Can you try another ACE? Yes, you could. Or you can go to an angiotensin receptor blocker, the ARBs. Angioedema, this is very dangerous. Patients can lose airway. They usually come in with their lip swollen like this. They have angioedema due to ACE. ACE cannot be used of any sort after that. I wouldn't even use an ARB, although they should be safe. Danger, you can't use ACE inhibitors in pregnancy. They're teratogenic. And in patients with renal artery stenosis, excuse me, can't be used. A little fluid, and I'm back. You can't use it in hyperkalemia. Okay, patients, be careful. We use them in renal patients, but just realize that they can cause some elevation of the potassium. and be very careful. ACE inhibitors and NSAIDs, particularly in the diabetic, can result in renal failure. Okay, so ACEs, very important, very powerful. Just realize that they have a few issues you got to be careful of. Angiotensin II receptor blockers, or the ARBs, losartan, which is nice generic. They're not a $4 med yet, but getting close. Get my little drawing tool here. Hypertension, CHF, renal protection for those who can't tolerate the ACE. Go with the ACE first. It's cheaper. Lisinopril is $4 at the Walmart, the old HEB, versus the ARBs, which are still more expensive. Metabolized in the liver. It can cause hypotension, and just like the ACEs, you can't use the ARBs in pregnancy. Hope you're hanging in there okay. This is a new case for us, a 78-year-old male with hypertension who's on HCTZ. Blood pressure is 180 over 100. So he took his wife's blood pressure med. Are you kidding? You know what happens? Sometimes they tell us, sometimes they don't. But it worked like a charm. Within an hour his blood pressure was down on their little cuff and he was feeling great until the day of a clinic visit. He was reading the newspaper. His wife saw his head go down. And then he popped back up. Well, she thought maybe he fell asleep, but then he did it again, and he would go right back to reading. That was a little scary. So she brought him in. She brought her medicine that he had taken surreptitiously. I like that word. Cardizem LA 360. His blood pressure is 100 over 60. His pulse is 40, and I'll show you his EKG. All these cases, by the way, are real cases that we'll discuss throughout the year. I don't need to make them up. Life is stranger than fiction. Huh? Okay, let's do our little 12-pack here again. Let me get my little crayon out. Go with a nice yellow. Okay, here we go like we did before. Let's see. The rate, 300, 150, 100, 75, 60, 50, 40. Whoa, so the rate is really slow. There's definitely a sinus bradycardia. And now I'm looking to see if there's a P wave before every QRS. And so there's a P wave, but there's a P wave, no QRS. There's a P wave. There's a P wave. There's a P wave. Notice the PR intervals are all different. Whoa, there's a P wave, no QRS. There's a P wave almost on top. Oh, there's one there. Whoa, there's one sitting right on the QRS. This is messed up. This is definitely messed up. Whoa, whoa, whoa. Whew, this is ugly. This is a complete heart block. This is third-degree heart block. The atrium, and if we had what's called calipers, we would see the atrium are marching out, just going along at their own little speed, totally. And there's a P wave buried in that T wave. See how different the T wave is? So we know there's a P wave there. So there's one in here too. So there's P waves are marching out by themselves, and the QRS are doing their own thing at their own rate. They're just totally ignoring the P waves. So this is a complete heart block, or third-degree heart block. Very dangerous. This patient needs external pacer pads, and the external pacer turned on, ready to go if things go ugly. Right now he's holding on. There's asymptomatic, but get those pacer pads on and get those pacer leads on just in case. Now, what in the world happened to the patient? Here he was doing well on his HCTZ, and he goes and takes this diltiazem. And the problem is diltiazem, cardizem, is a central acting calcium channel blocker. It blocks at the AV node. And so he poisoned his AV node. He just shut it down. The big old whopping dose of cardizem and diltiazem, and he develops third-degree heart block. And this is why we never give medicines like beta blockers or calcium channel blockers, particularly the central actors like verapamil, diltiazem, without doing an EKG. And we certainly don't want patients at home taking medicines they have no idea what they're doing and end up with a complete heart block and a pacemaker. Bah! Bad form all around. So let's just look for just a moment at calcium channel blockers. We have both the central actors, as demonstrated here. Get our pen back by diltiazem, and then the peripheral actors, or the dihydropyridines, by a medicine I like, the amlodipine, or Norvasc. Central actors, they work through calcium channels, both of them, but the central actors block the AV node. The peripheral actors just work on the peripheral arteries to vasodilate. Okay, so they can be helpful in Raynaud's. That's interesting. The calcium channel blocker centrals can be helpful in angina, hypertension. They can rate control in atrial fib or supraventricular tachycardias. So there's a nice place for them. Some of you may have seen cardizem drips in the ER or on the floor in the CCU, ICU, blocking that AV node down in the setting of atrial fibrillation or SVT. So the central actors have their place. I've got to admit that most of us don't use central acting calcium channel blockers for hypertension any longer because they cause some issues, precipitating MIs by causing some what's called coronary steal. They would dilate an artery here, and a blocked artery would get nothing, and all the blood would go the path of least resistance to this coronary artery, and there would be an MI. But that was with the short-acting calcium channel blockers. And we just don't use any short-acting calcium channel blockers anymore. In fact, when I was a pup, Procardia, we would give it under the tongue, have them chew the capsule or put a little hole in the capsule, and it brought down the blood pressure quick. The problem is it caused a coronary steal, and we were killing patients. So that's why we don't do short-acting central calcium channel blockers anymore at all, period. So some of the problems with the central actors, bradycardia. You can kill patients with WPW. By blocking the AV node, you force all the electricity down the accessory pathway, putting them into a reentrant loop, which can deteriorate from SVT into VTAC, VFib, and death. So we don't want to use them in any sort of second-degree block. You have to be careful in CHF because they're negative inotropes. They decrease the pump, and so patients can actually have worsened CHF because they're negative inotropes. They decrease the strength of the pump. And of course, what we talked about, no short-acting central calcium channel blockers. That's a black box warning. Don't do that. Amlodipine and Norvasc is a peripheral vasodilators, very good in hypertension and Raynaud's we mentioned. The patients do not like this. I know. The leg edema, because it dilates, it can cause some leg edema in just about everybody. You just have to warn them that's a possibility. Particularly the ladies don't appreciate that. Sometimes the patient's already on HCTZ, hydrochlorothiazide, or chlorthalidone, the thiazide diuretics, so they already have a little diuresis that will decrease the chances of that edema. Can cause hypotension. Leg edema is the main thing. It's not quite cheap yet. It's generic. I'd like to see it get to the $4 list because it's a good medicine, particularly for the older patient. Okay, Digoxin, really not a big place anymore. It used to be a go-to med for CHF because it's a positive inotrope. It squeezes the heart. We used to use it in atrial fib because it blocks the AV node, but dig toxicity is mean. Okay, dig toxicity not nice. GI upset. It's proarrhythmic, can cause paroxysmal atrial tachycardia. They have yellow-green halos around their eyes. They can get delirious. You can't use it in Wolff-Parkinson White. You've got to be careful with it in hypokalemia, hypomagnesemia, hypercalcemia because it is a proarrhythmic. So I doubt you'll ever use Digoxin without the consultation of a cardiologist. It's just not. So I just mentioned it because there are still some patients on it. Most of those patients are 70 or 80 and won't be with us a whole lot longer. Nitrates. These are very powerful vasodilators. Nitroglycerin, of course, is the most famous. Can be used sublingually. Patients with angina, MIs, peripheral vascular disease. And a neat way of using it is putting the paste or a patch on the leg that has the bad peripheral vascular disease. It dilates the arteries and can increase the flow to the leg. CHF has its place in decreasing the workload of the heart, as well as helping with pulmonary edema, so patients will have less shortness of breath. It can cause, and patients do not like this, a terrible headache because of the vasodilation, as well as orthostatic hypotension. Be careful, be careful, be careful. You can't be taking Viagra, Cialis, Levitra with patients taking nitrates. Okay, you can cause severe hypotension. The other thing is, over time, patients develop some tolerance tachyphylaxis to the nitrates, so that's why things like Imdur is used no more than twice a day, the last dose usually at 5 o'clock in the afternoon, to give patients a true 12-hour break so that the medicine maintains its effectiveness. Okay? Nitrates. Okay, here's another case for us. Get my magic pen. I love all these colors here. Ooh, that's nice. It's a 50-year-old truck driver. Noticed blood in his urine. It's close to blood in the urine here. 2 days ago, while driving, he thought it was his red Gatorade, changed to blue Gatorade, but still had red in his urine. Go figure. He has hypertension and takes Lasix, 40 milligrams a day. He has hyperlipidemia and takes Zocor, 20 milligrams q-day, the statin. He is a smoker. He took a Z-Pak this week since he had a cough. Blood pressure in the clinic is 145/90, pulse 60. He's satting pretty well. Not bad, 94%. Makes me wonder if he had been a smoker. Urinalysis was positive for blood. The dip was positive for blood. Protein was 2+. But the micro, interestingly, had no red cells. Very interesting. So that makes us think, what in the world is going on with this truck driver who sees blood in his urine? Well, what do you think may be happening here? When you see a dip positive for blood, but no red cells, dip positive for blood, but no red cells, there's only two possibilities. Either myoglobin in the urine from breakdown of muscle tissues, or hemoglobin from breakdown of red blood cells. Well, we have no reason to suspect hemoglobinuria, no history that would suggest hemolysis, breakdown of red blood cells, but it is interesting that the patient is on Zocor, and the simvastatins, the statin medicines, can cause a rhabdomyolysis, a breakdown of muscles, and then that myoglobin gets into the kidneys, and it comes out in the urine as pink, red. It's not blood, it's actually myoglobin. The problem is, if the patient's dehydrated, the myoglobin can clog up the collecting system, the renal cells, the renal tubules, if you will, and suddenly we have a patient with acute tubular necrosis. Very dangerous. Those patients have to be hospitalized for really lots of IV hydration with normal saline, try to get them peeing out that myoglobin. Sometimes we have to alkalize them with bicarb. So be careful. Here's a patient who's been taking Zocor and been doing well, but it's the Z-Pak and that P450 system. What happened in the Z-Pak increased the risk of the patient having rhabdomyolysis. So we have to be careful. We can't just be chucking Z-Paks at people. Did he need a Z-Pak? I don't know. Let's really think it. Did he have a change in sputum? Did he truly have an acute bronchitis just because he had a cough? Well, he was a smoker. I'd be more interested. But I've got a guy that's otherwise fine. He's afebrile, and he has a cough with some sputum. Big deal. We all get that. No reason for a Z-Pak in this case, from what I can see. That Z-Pak caused a deleterious effect on his myoglobin system, on it caused a rhabdo, because the Z-Pak allows the Zocor to be in the system more, right? They're fighting for metabolism in the liver. And so suddenly a guy that was doing fine has a real issue. The other thing is a problem. Lasix is not a good medicine for hypertension. It's a good medicine for CHF. It's a good medicine for cirrhosis. You need to mobilize fluid. But it's not a good antihypertensive. By itself, not a good choice at all. So that dehydrates him. making them even higher risk for having kidney injury from this rhabdomyolysis. The case is somewhat complex, but I wanted to introduce you to the concept of rhabdomyolysis and the problem with the myositis, inflammation of the muscles that can happen in patients that are taking statins. Okay, so let's talk for a minute about the different types of antilipid medicine. The bile acid sequestrants, like Questran, you won't see a lot of patients using those. They make patients gassy and somewhat miserable. Niacin, it's a stinker. I mean, you think, gee, just a vitamin B. The problem is it causes flushing. It can cause hyperglycemia, hyperuricemia, i.e. precipitating gout, as well as elevated liver enzymes. So, the lipids, the gamfibrozole, the fibric acid medicines, decrease triglycerides, and then the statins, like Zocor, Lipitor, Crestor. Let's look at the different classes and their effect on the cholesterol system. The bile acid sequestrants will decrease the LDL some. There's niacin. It will elevate the HDL. There's our friends the statins, decreasing LDL, increasing HDL, decreasing triglycerides. Gamfibrozole will decrease the LDL some, change the HDL up. Of course, you want the HDL a little higher, you want the LDL down. But its power is in the triglycerides. Okay. Let's see another gamfibrozole there. And there's our omega-3 fatty acids. A good choice for patients, particularly powerful here in the triglyceride area, decreasing triglycerides. The problem is it can increase the LDLs. So just realize the omega-3 fatty acids, their power is in the triglycerides. Okay, let's talk a little bit about the troubles with these medicines. The bile acid sequestrant, poorly absorbed, they get bloating. They also decrease absorption of vitamin A, D, E, and K. That's not good for the eyes, not good for the bones, not good for antioxidants, not good for the clotting system. They also increase triglycerides. The fibrates, like gamfibrozole, it can cause hepatitis and rhabdomyolysis. Niacin we talked about can cause hepatitis, gout, and diabetes worsening. And finally, the statins can cause a hepatitis, rhabdomyolysis, interacts with the P450 meds like the macrolides, like the old Z-Pak or azithromycin. And you have to be careful with grapefruit juice. Not a problem for me. I like grapefruit, but I'm not a fan of the juice. A little too sour. Okay. Our last case of the day is a 61-year-old female with 3 days of worsening right big toe pain. She can't sleep due to the pain. She has tried Tylenol and Motrin without relief. Her past medical history includes hypertension, and she is fairly well controlled, or has been, with HCTZ. And she takes 6 vitamin pills a day for cholesterol lowering. Who knows where she got that idea? Maybe from Aunt Beulah. And she gets red in the face when she takes her vitamins. Her blood pressure in the clinic is 145/88. Pulse is 80. And she has the right first metatarsal phalangeal is red hot, tender. It's not, it's hot. Tender and edematous. Oh man, oh man, oh man. Right big toe, painful tender, that sounds like, yes, gout, doesn't it? Ooh, how did that happen to this lady? Well, let's look. We talked some of the issues that are a problem. HCTZ increases reabsorption of the uric acid there at the distal convoluted tubule. That's a bit of an issue. And we mentioned, red in the face. What medicine did we talk about that causes flushing? The old niacin. Gets a bunch of B vitamins in there, takes a handful of those babies and causes flushing, but niacin also increases uric acid. So not only did the HCTZ increase the risk of gout, but so did these vitamin tablets. Patients think the vitamins are a panacea with no side effects. You have to help educate them on their benefits as well as their risks. So what do you do with this patient? Well, someone that has gout like this, you really got to say, HCTZ is probably not the best choice. She's 61. A calcium channel blocker like amlodipine, start at 5 milligrams Q-day would be reasonable. And she also needs to know that she shouldn't be taking 6 vitamin pills a day. Maybe less of those would be helpful. At best, maybe none, and just a more well-rounded nutrition. So let's talk diuretics here for a moment. The loop diuretics. Of course, Lasix is the one that you'll see used or misused mostly. So there's all Lasix, works at the loop of Henle, inhibiting sodium reabsorption. Decreasing plasma volume, that's how it decreases blood pressure. Though we mentioned it's not a great blood pressure med, but it is very good in acute CHF as a diuretic. Some patients end up taking it daily because they just don't control very well their sodium intake. It's good in mobilizing cirrhosis, for mobilizing acidic fluid, ascites. Good in nephrotic syndrome, patients that don't have the protein, the oncotic pressure to hold fluid in, and they leak lots of fluid into their extremities and get lots of edema. The Lasix is useful there. The problem is, it makes sense, right? It's a diuretic. It can cause dehydration, hypokalemia, hyponatremia. It has been known to cause pancreatitis. I'm thankful I've never seen ototoxicity. Do beware in true sulfa allergic patients, there is some cross-reactivity with the diuretics and sulfa allergies. Thiazide, very commonly used. I'm a real fan of HCTZ. Some of my colleagues are more purists and like the hydrochlorothiazide, or like the chlorthalidone. It is the med that was used in the hypertensive trials to show decreased mortality in the elderly. It works in the distal convoluted tubule, inhibiting sodium resorption. And like other diuretics, it decreases peripheral vascular resistance, decreases plasma volume, and therefore decreases blood pressure. It is very useful in hypertension, particularly in the elderly. It decreases some edema. Don't get into the bad habit of giving this for every sweet old lady that has leg edema. It's because of venous insufficiency. Let's get some TED hose. Let's decrease salt load. Let's elevate the legs when resting. Not the wisest thing to be chucking HCTs at all those folks. It can help in osteoporosis because it increases the reabsorption of calcium at the distal convoluted tubule. Now the problem is it can cause wasting of potassium, wasting of sodium, increasing the reabsorption of glucose. It can precipitate gout, just like we talked about with the patient a moment ago. It also increases triglycerides and LDL. Okay, so there's a number of reasons why you want to think about the benefits as well as the risks of thiazide diuretics. I'm a real fan. They've been shown to decrease mortality in the elderly, particularly good for systolic hypertension, a good first-line agent. And finally, the potassium-sparing diuretics. You'll use those mainly in patients that have severe CHF. They mobilize fluid well in cirrhosis. It has been shown to decrease some hirsutism. You got to be very careful, though, of hyperkalemia, particularly in renal failure patients. Okay. So today we have gone through the different cardiac meds, from the antihypertensives to the meds that help in MI, like metoprolol, beta blockers, nitrates. We've talked about some of the benefits of ACE inhibitors and CHF, ARBs, the renal protective effect of ACE inhibitors and angiotensin receptor blockers in the diabetic. We've gone over some cases. Now, the next 3 weeks, each week online under the My Campus, there will be one clinical quiz. That is a study quiz. So each week there's a study quiz, a total of 3 between now and our next class time. Because the next class time you'll have an exam. That will be 50 questions, 4 points per question, 200 total. And if you study your quizzes, you will do fine. Once again, if you study those 3 quizzes, 15 questions apiece, you will do fine. You'll find that there's the quiz and the answers, so you can look at both. And they're open for even now. Each week there's a little case study for you to read and to answer. It does not need to be in the APA format. I'm a clinician. I think, in terms of soap notes. So answer the question. You're certainly welcome to put in your bibliography if you want to, but I'm really not interested in that. You have plenty of that kind of writing in your other courses here in your master's program. I'm interested in your thinking about how to problem solve clinically. Okay, so I mean, use good English, but they can be short answers. Boom. Don't send me 3 pages. Okay, I really don't need that. That's for your other courses. Okay, I look forward to seeing you. Hopefully, canoe or kayak out of this wet mess, and see you on, I believe it's September 15th. God bless and goodbye.